super specialty webinar series of adolescent cardiology. तो हम लोग इस साल है ना जनवरी से हम लोगों ने वेरियस सुपर स्पेशलिटी टॉपिक्स के ऊपर वेबिनार्स किए हैं एंड ये 10th है इस सीरीज का। आप सबका स्वागत है। अब हम डॉक्टर हिमा बिंदु सिंह मैडम को फॉर्मल वेलकम एंड स्पीच के लिए इनवाइट करते हैं मैडम।
Dr. Arya sir, thank you. And
Sir.
actually, I'm coming back after a short break, but
Yeah.
I'm not in full form yet. I'm
Yes.
just recovering from a bad throat, fever, and was not able to talk actually the other day. So give me some more time. But then I was thinking AHA cannot stop. All of us are a bunch of very passionate people. Just now I was mentioning, and Adolescent Health Academy is celebrating its silver jubilee year. So nothing should stop, and enthusiasm and the energy should flow. So I said that let us do this webinar, though it is 1 week little later because I was struggling to get these cardiologists. They are so busy. I mean, after Vijay Lakshmi has probably sent her, but the other cardiologists, we were not able to get their photos and all those things. Anyway, so they're all part of our family now. And then we are now conducting this super specialty webinars. Actually, this year, for all the cardiology friends, in fact, Adolescent Health Academy is a sub-chapter of Indian Academy of Pediatrics, like you all must be aware. We are 3,400 passionate, dedicated pediatricians working for adolescent health. And this year, we're celebrating a silver jubilee year. So it's a 25 years old AHA. And this year, we have done a lot of unique activities. My whole executive board, along with Dr. Geeta Patil, my past chairperson of our AHA, and Sushma Desai, and who's going to take over the chair, and Dr. Arya, Dr. Shamik Ghosh, and of course we have Arun Sharma always with us, and Dr. Sudhir Mishra, who's one of our senior he's executive board member of our AHA, but is also the scientific chair for all our scientific programs. He's very much here today, and all the EB members of my executive board this year. We had a very good programs going on this year. And one of these programs was the super specialty webinars. So we used to talk on many subjects, mostly on social fronts like substance abuse, mental health, metabolic health. All this we have taken up in a youth wellness program, which goes to the community. And 1 year just ran away like this, 9 months we worked very hard, and we are in the 11th month now, and we still have to reach out to the community. So, and we have taken a promise to reach out to 1 million adolescents through a Hyderabad declaration, that we have involved even 7 other organizations, that we all will work together to reach out to 1 million adolescents. Hope we'll continue to do this program in the next 3 to 4 years, because nothing happens in 1 year. We need to really sustain our programs for at least to see the impact for another 4 to 5 years. So, Vijayalakshmi ji, yes.
I would like to suggest, if you really want to reach out to the adolescents, start going to the schools and colleges as chief guests.
Exactly.
And that's what I do,
Yes, okay.
I do one sapling, put the sapling and talk to the people. You make it catchy, like personality management or key to success. And then you can give them the what exactly you want to
Yeah.
do. And
Yeah.
I think all of us should go to the colleges, and I
Yes.
do that.
Yeah, actually, most of our pediatricians here in HA are already working in the community. They are really good. A lot of good work is happening, and our reports are full of community work. And this was one initiative. And we also started our youth forum, where we are all working for the youth. So we started involving them into our activities and asking them what they actually want from us. So that was one new initiative. And we also done this parenting, futuristic parenting. We have updated our parenting scientifically, because of changing times, we need to really update ourselves. So that was another initiative, and counseling programs were done. And super specialty webinar was one thing, we thought, let us go above the routine topics. And these were hardcore scientific. And every super specialty webinar, whether it was dental, orthopedics, mental, psychiatrists, we involved the specialists actually. So I think it was well attended, and the endocrinology, some of them were really good. So I think this webinar on cardiology, adolescent cardiology, will also be a super hit. And having all of you on board, really thank Dr. Vijay Lakshmi, who's actually the WIN card. Did you hear about this?
Yeah.
The
Women in
cardiologist,
cardiology.
women in cardiology. So they run a forum, cardiology में women in cardiology. इसके head है Dr. Vijay Lakshmi ji, very vibrant personality.
I'm
And
not the head, but
uh,
I'm the senior most,
okay.
the oldest.
And yeah, and Dr. Nitin Rao, who's consented to be part of our moderator for the panel discussion. He's from Hyderabad. He works closely with pediatricians, so I know him very closely. And I worked in Nilofa Hospital. He used to come there and see our cases.
Thank you.
And likewise, we have all the panelists today from different parts of the country. We have Dr. Smita Mishra, who's been interested in cardiology. And we have Dr. Lingaswamy, from AIG Hospitals from Hyderabad, and Dr. Shikha Swaroop from Jamshedpur,
Jaipur.
and Anamika Jain. She is from Delhi, Anamika?
Jaipur.
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 So, yeah. So we have all these people here, and thank you for being part of this. I feel that, this all recordings will be available for those who have missed today or not able to attend. So I wish this webinar great success. I hope we can get some inputs, because what we have taken up today, topics what scientific chair has suggested, that we talk about sudden cardiac deaths in young people. We see a lot nowadays. We really wonder, it is no more an age after 50 wala baat. Even 20s, 30s may be losing people suddenly. So what could be? Cardiac reasons are there, non-cardiac also, but let us hear from the experts. And Dr. Nitin Rao will also discuss about other common problems which are seen in this age. So with this small introduction, I request Dr. Geeta Patil and Dr. Sushma Desai, our chairpersons, to speak few words before we start with our Sudhir Mishra sir introducing our first speaker. Dr. Sushma Desai.
Yes. Very good evening, dear colleagues, and Dr. Hima Binduji, Dr. Vijaya Lakshmi Madam, Dr. Geeta Patil, Dr. Arun Sharma, and all the dignitaries, Dr. Sudhir Mishra sir, all the dignitaries and the esteemed faculties who are going to enlighten us with their knowledge today. It's always a pleasure to welcome you all to the super speciality webinar. Today's webinar being on adolescent cardiology. I would say we are trying to bridge the gap between pediatric and adult heart care. That is what I think we are aiming at. Like other unique challenges, the adolescence is also the time when previously silent congenital or inherited cardiac conditions may first become evident, and when issues such as hypertension, obesity, and arrhythmias begin to surface. So there are multiple reasons, and we are still trying to figure out what are the reasons behind the sudden cardiac arrest in young people. So we are looking forward to a great enlightening discussion from esteemed speakers like Dr. Vijaya Lakshmi Madam and rest of the speakers. Looking forward to a great success of this webinar as well. Thank you so much for giving me an opportunity. Thank you.
Sushma ji. Dr. Geeta Patil ji.
Thank you, Dr. Himabindu ji. I think after a long time we are back again, and definitely adolescent cardiology is a topic to be discussed, because many times the children climbing up on the steps, we lose them. On the sports ground, we lose them. And maybe we are not very well versed with many things. I'm not telling emergency. At least in our clinic, we should know whom to evaluate. Now, Kawasaki is there. So many things are there, and lifestyles have changed. Cardiac problems are going to be hypertension, which was supposed to be in the adult age group. Now we are observing in the adolescent age group. So all these things, if we know some tips and how frequently we have to assess, and which cases we have to assess, if we know, definitely we can save many lives also, and maybe morbidity, mortality, both will be reduced. And I'm very sure all the eminent faculty, Dr. Vijay Lakshmi Madam, Smita Mishra, Dr. Nitin, and Madam has mentioned Lingaswamy, and all definitely are going to enlighten us. And thank you, Dr. Himabindu Madam, for this great initiative of super specialty webinars. Thank you very much once again for giving me opportunity. I think
Thank you.
see on the screen all dignitaries are there. Dr. Sudhir Mishra, who is a scientific chair, then Dr. Arun Sharma, uh, Sushma Madam is there, Shami Ghosh is there, and Shikha Swarup also. I think I've heard her before. Geeta Bansal Madam, Rashmi Gupta, Rashmi Divedi Madam. I think thank you very much. This will be really a very useful and unique type of webinar which will be useful to everyone. Thank you very much.
Thank you, Dr. Geeta. So we have all the today's speakers are specialists in pediatric cardiology. So this is a very special webinar for us and a lot of take homes for us. Dr. Shamik Ghosh, our Joint Secretary, is also here. Wanted to introduce him. So over to you, Dr. Sir, Scientific Chair, Dr. Sudhir Mishra, sir, who's from Jamshedpur, Senior Pediatrician and EB member of our 2025 AHA. Over to you, sir, to introduce the first speaker.
Thank you, ma'am. Thank you for the kind words. I welcome our faculties, Dr. I.B. Vijayalakshmi, Dr. Nitin Rao, Dr. Smita Mishra, Dr. Lingaswamy, Dr. Anamika Jain, and Dr. Sikha Swarup. The panelists will be introduced by the moderator of the panel discussion, Dr. Nitin Rao. So my job is to introduce the two eminent faculties, Dr. Nitin Rao, who is Chief Pediatric Cardiologist at Star Hospital, Hyderabad. He is MD Pediatrics, then DNB Pediatrics, then DM Cardiology, Pediatric Cardiology, and then again DNB Pediatric Cardiology. So many degrees. Welcome, Dr. Nitin Rao.
Thank you, sir. Thank
Nice to know you.
you. Nice to meet
Dr. I.B. Vijayalakshmi, I feel, needs no introduction in the field of pediatric cardiology. She is the first lady cardiologist and the first one to start pediatric cardiology in Karnataka. A former professor and head of pediatric cardiology, in fact, a emeritus professor emeritus. And she is MD, DM, DSC, FICC, FIAMS, FIAE, FC, SI, FICP, FAMS, FISH, and FRCP. I don't know meaning of many of these words even.
you.
Welcome. And her contribution, which is pioneering really, is the echocardiographic criteria for rheumatic heart disease, which used to be very prevalent, is still there around us. And as it becomes less prevalent, I think it becomes more important for us to keep information and knowledge about the subject and do not miss these as congenital heart disease. So I invite Dr. Vijayalakshmi for her session on sudden death in adolescents and young adults. Welcome, ma'am, and the stage is yours.
Thank you very much, sir, for your kind introduction. And let me start with the sudden cardiac death in the young. I know nowadays, every time a child or a young person dies, they a rush of TV discussions. Hours together we discuss and then we forget. But we must remember that the heart is the most precious one and it is the greatest treasure that we have got. And everybody thinks William Harvey is the father of cardiology. But in fact, even before the Vedas in Narayan Sukta, what is heart? It is explained. It is a place of omnipresent universal God, and it is in the center of all the blood vessels, oscillating in the chest on the left side. First, it takes nourishment to itself, and then it supplies to the whole body. Now we know that coronaries are the first branches which supply to the heart, and that's how the heart attack occurs. And in the center, Agni is installed in the subtle form, and then universal Paramatma. Then it maintains temperature from head to toe, and subtle molecule installed in the heart itself is Brahma, Vishnu, Maheshwara. And if the blood supply is there, the body cells grow. And the nourishments, if the blood supply is important, and to perish also, then there is a blood supply stops. And the heart is a tremendous one, and it is the best example of the harmony and the strength. And all are non-phenomena is that all the muscles like a syncytium function together, and every time the blood is pumped, it goes into the 60 miles of blood vessel, that is like going around the world 1.5 times. And every time the heart pumps, not only it travels for the whole day, it pumps around 4 to 5,000 gallons, and that is an enormous pumping capacity. And for that, with that fuel, we can take Queen Elizabeth ship from London to New York and back to London, and that is the 1 days of energy. And that's how the heart is a greatest treasure. In fact, the heart possesses 1 lakh times more electric and 5,000 times more electromagnetic power than the brain. So person can live with the brain death or any organ not working, but once the heart stops, within 3 minutes we declare that person as dead. And so what is the sudden cardiac death? The main causes of the sudden cardiac deaths are genetically inherited or congenital heart diseases like hypertrophic obstructive cardiomyopathy, coronary anomalies like Alcapa, that is the anomalous left coronary artery arising from pulmonary artery, arrhythmogenic right ventricle cardiomyopathy, or long QT syndrome, Brugada syndrome, or inflammation of the heart with the viral myocarditis like the Kawasaki's or Corona or any of them. And in rare cases, severe blunt chest injury to the chest while playing on the ground, and that is called as the commotio cordis. And then bicuspid or unicuspid aortic valve with the stenosis, and the sudden death can occur when they are going to the school or other thing. Then Williams syndrome, Noonan syndrome, Wolff-Parkinson White syndrome, that is the WPW syndrome. Invariably, it occurs when there is a what to say, like the accessory pathway. Then cardiometabolic syndromes are there, and more than that, nowadays the drug abuse is the most important one, and that is taking the topmost position. And then the noise pollution, and then the air pollution, and the lifestyle modification causing the stress. So these are main things which are causing the sudden cardiac death, which strikes like a bolt in the blue, devastating the family with the unfathomable misery and to the parents. And it is shocking to the whole society when a child suddenly dies while going to the school or running in the corridor, or when the person playing the game on the ground, he falls dead. So these are the sudden, what is sudden cardiac death? It is unexpected death for the cardiac cause occurring within 1 hour of the onset of the symptoms in a person who was previously healthy or whose condition wasn't expected to lead to death. You must have heard that people that jumping and dancing, and as they're dancing, they fall. And many of the youngsters are dying like this. And here they have two types. One is the cardiac arrest, that is the arrhythmic death. So when the arrhythmia occurs, ventricular fibrillation, agonal rhythm, and the death, and that is the cardiac arrest. The other one is the heart attack, that is cessation of the blood supply to the heart through the coronaries when they have got the thrombosis or the block. So here, starting with the cardiac arrest is the sudden and unexpected cessation of the heart's pumping function, causing a lack of blood supply to the brain, and so the person becomes syncope or falls unconscious, and then they becomes difficult to revive them. So cardiac arrest is the leading cause of death in young athletes. Estimated vary from reports suggest that about 50,000 young athletes to almost 1 lakh die suddenly every year. And this is all over the world. But in our country also, we have seen this happening. And what is the force that hits the chest? When they have an injury to the chest, then also they can have. And here, either it is the sports equipment or other equipments which can cause the injury. So instead, it changes the heart's electric signaling, and as a result, it triggers the ventricular fibrillation, leading to the cardiac arrest. So, how can the parents or the coaches or the pediatricians or the doctors assess these people? Here, the many times the sudden cardiac death occurs without warning. So it is impossible for anyone to guess. Or warning signs may occur, but they go unnoticed. So if the child has got fainting, most of the people think that the child has not eaten anything and then hungry or hypoglycemia. But syncope is one step short of the death. So any child with the syncope should be evaluated properly. Then shortness of breath or the chest pain. If the child complains of the chest pain or the young person, it has to be evaluated. Don't neglect it. And apart from that, any breathlessness, unless the child has got a bronchial asthma or something else, that has to be ruled out. But the conditions such as asthma also can cause, and one pediatrician can distinguish between that, because the wheezing and then seasonal, all those things are there. The family history of the sudden cardiac death has to be taken. Unless you talk to the family members and find out, many conditions like a hypertrophic obstructive cardiomyopathy or long QT syndrome all can be missed. And if you take a proper history, you can decide. So, for example, this is a 20 years old person. He was brought to the emergency OPD with unresponsive state, not responding to anything for 3 days. And you can see that this is the ECG. This is the torsade. So once you have a torsade, that means it is a polymorphic VT, and then this polymorphic VT can occur in the long QT syndrome. And these children with the long QT syndrome, the moment the bell rings or the phone rings or some loud noise comes, they just get the VT or VF and then suddenly fall unconscious. And that's how we know one has to take the history. Now, coming to the Brugada syndrome, invariably it occurs between 30 to 40 years, but any age it can occur, right from childhood to the 60, 70 years, the Brugada can be expressed. So here it is a genetic mutation, and as a result, the heart's electric system, specifically the ion channels, are affected. And ECG pattern is very, very important. Here you can see that in this 35 years person, this is the classical picture of Brugada syndrome. And once you know these are QRS is widened and the ST elevation is there, and then it doesn't fit into a typical heart attack patient or the myocardial infarction. And here the patient requires the intracardiac, defibrillator. And then this is a child who was operated earlier, and after operation, the child, cyanotic child, and now has come with the VT. And this happens because in the olden day, they used to do the ventriculotomy. The right ventricle, they used to cut to go through the right ventricle to put the patch for the VST. But now it is no more. And if the scar is there on the sternotomy and the history is there, and the ECG shows like this, that means it is the post surgery ventricular fibrillation. And this is the child was diagnosed as a mitral stenosis, rheumatic heart disease with a mitral stenosis. But when they look at that, it is the tumor. The tumor is coming and going. That is almost blocking the mitral valve. This is the left atrial myxoma, which is coming right into the mitral valve. So anytime it can embolize, or even otherwise, the sudden deaths are definitely known to occur when this happens. And this is a patient with the hypertrophic obstructive cardiomyopathy. You can see that the mode echo and the short axis, the mode echo both in the ventricle as well as the aorta, you can see that this is called as the SAM, or the the septum is almost touching the, almost touching, and it is closing. So the cavity of the ventricle is totally closing, and sudden cessation of the aortic valve, and then the hypertension occurs. And apart from that, you can see that the interventricular septum is so thick, and then it is almost obliterating the LV cavity. And this is the apical cardiomyopathy where the T waves are like this. And in such patients, you can definitely make the diagnosis and literally save these children from death by intervention. So all are not lucky like this child. So this child was diagnosed as rheumatic heart disease with the mitral regurgitation, put on penicillin prophylaxis. The moment I saw the echo, and I knew that it is not rheumatic because you can see that there is a glistening endocardium. Once you have a glistening endocardium, that means there is a subendocardial ischemia. That ischemia occurs when there is a alcapa. So we did the coronary angio and confirmed the diagnosis. The left coronary artery, it is not arising from aorta. So familial hypercholesteremia is very, very important. The youngest child I have done the angiogram was with the triple vessel disease was a 9 years old, and they had the xanthelisma studied all over, and the cholesterol was almost 1200 total cholesterol. And another child, 19 years old child with the 1500 cholesterol had an anterval MI. Say these children, if we do not examine and look for this deposition of cholesterol built up in the elbow, knee, and hands, and the buttocks and other places, we will be missing the diagnosis. They have to be treated. And in fact, the drugs do not help here. They have to go for the liver transplantation so that the production of the cholesterol itself is changed. Now the lifestyle changes have dramatically changed the pattern of coronary artery disease. And once upon a time, the children used to bring their parents. Now the parents are bringing the children with the chest pain. And as the diagram shows here, whenever the cholesterol deposition is there, once it becomes the thrombosed and 100% blocked, the myocardial infarction occurs. If the left main occurs, the sudden death can occur, and that happens if the child, if they have got the diabetes for a long time. Almost 13 times more left main diseases and sudden deaths among the diabetics than the non-diabetics. And now type 1 diabetes is common in children, and the cardiometabolic syndromes are also very common, and the children going for the smoking also has increased. And the smoking in women, it can affect the embryo. And apart from that, the children smoking at a younger age, and they can get a heart attack at a very, very younger age. So ECG has to be taken. So other conditions like, if they have bacterial endocarditis or gastroenteritis, hypertension, or hypovolemia, all these conditions can cause the attack. Now, many people are taking coffee in a lighter vein. So everybody thinks that the coffee gives the energy, and then, but the headache, insomnia, nervousness, irritability, frequent urination, all these things, that the fast heartbeat, are all forgotten. But what is most important is, if the caffeine content is more, they can have the sudden cardiac death. And apart from that, the vitamin D deficiency can cause the sudden cardiac death. This, many people are not aware of it. And what happens is, vitamin D deficiency can increase the risk of cardiac death, particularly from the sudden cardiac death, and that too the heart failure due to the hypokalemia and arrhythmia. And the milk is the best supplier of the vitamin D and the calcium, and the exposure to the sunlight also we get the vitamin D. And that too the Indian cow, which is the type 2 milk, that contains, it is very rich in B12 as well as the vitamin A, D, and the riboflavin. So that's how it is very important. But unfortunately, our younger children, instead of drinking milk, they have started drinking the aerated fizzy drinks. And this fizzy drinks, you can see that each bottle contains about 40 milligrams of caffeine, like drinking 6 cups at a time. And that's why it looks like the coffee decoction. What is more important is, It contains phosphoric acid, which depletes the calcium from the teeth and the bone. So just depletion of the calcium is not important. What happens is calcium phosphate gets deposited in the kidney as the stones, and more than that, what happens is the obesity is more in these children, and that too they are drinking the cold ones. And the metabolic syndrome, or the syndrome X, or the cardiometabolic syndrome in the children, is the main cause, mainly because of these fizzy drinks. And that's how, one has to wake up, and the children should say no to that. And nowadays, especially in Bangalore, the recently survey was done. Almost 28% of the college students and 10% of the school children have started taking alcohol, apart from the smoking. So the hookah clinics are there by the side of the school, and that's how the children are graduating from smoking hookah to the cigarettes, and then to the marijuana, that is the ganja. And most of the deaths that occurred in this year, and we discussed, they were all because of the drug addictions. So alcohol can cause the fetal alcoholic syndrome, and more than that, the hypertension is 20 times more in the alcoholics, and the hypertension in turn causes the heart attack or the heart failure. So here the good cholesterol, bad cholesterol, everybody knows, but what is important is the good cholesterol increases only with the exercise and the not smoking. So the bad cholesterol, most of the children, they are pampered with the egg omelets and all that. One should remember that our body requires just 100 milligrams of cholesterol, and that is synthesized by our liver. But when each egg containing 250 to 330 milligrams of cholesterol, and they make 2-3 eggs together, omelette, and eat, the cholesterol deposition will be higher. So instead of that, the peanuts are the best. They have the double protein, and they're zero cholesterol. And that's how, dry fruits and the other things are better. But these trans fats are worse than anything else, because the most of the kurkures or the chips or whatever it is, they're all using this trans fat, that is the dalda or the vanaspati, and they are causing the crust in the what to say erytheromatous plaques in the arteries. And greater amount of cheese on the pizza, the more blocks in the coronary arteries, one has to remember. And the all these the western style of eating and the junk foods are studied with the not only the trans fats, with the salt and the sugar. And that's how these are not good, and that's how, it is causing obesity. And post corona, we have evaluated in Bangalore city alone, both children as well as the women, obesity has increased by 30%. The school going children themselves are becoming obese because they're eating the junk food. The junk food, you all know that it contains no nutrition, no fiber, no vitamins, no micronutrients. It is only salt, sugar, and the maida. And that's how we know the junk food can cause the heart disease, cancer, high blood pressure, diabetes, and all these are because of the bad eating habits. So the children should be encouraged to eat more vegetables, at least 2 to 3 vegetables, and these vegetables will have fibers, and almost 28% heart attack can be prevented by eating vegetables. The fruits are the best ones. They have the antioxidants, like, free oxygen radicals are removed like scavengers, and our blood vessels, especially the inner layer of the blood vessel, that is the endothelium, becomes healthy when we eat the fruits. And that's how the children should take up that. And they should go for the sports exercises, swimming, cycling, and also do the what to say, like the Surya Namaskara, which has got the 12 asanas in that. But unfortunately, today more and more youngsters are going to the gym, and we have seen that many people, when they go to gym, they are falling dead there. And this is a paradox, because physical exercise remains one of the best way to lower the heart disease and the risk factor. But in turn, when they go to the gym, they are dying. So what is that? We have never heard of anyone dying going to the Akhada, or the wrestlers dying who pray to Hanuman and then eat halwa, then badam and pista and milk. And why would this is happening? And this is how it's seen not only in Mumbai or Punjab, it is occurring even in Karnataka. And that is because they take the energy drinks. This energy drink contains about 50 to 70 milligrams of caffeine in that. So, though it makes the person feel very energetic and very happy, and this high content of caffeine in that creates the problem and the arrhythmias, and then it becomes the person becomes jittery and anxiety, headache, and then they can have the suddenly nausea, and then arrhythmia, syncope, and then fall dead. And more than that, the side effects of caffeine and the flushing, apart from that, they have the problem of addiction to the other drugs. So they have started, they start with the gym formula, and then they grade to the other drugs. And then, most of the youngsters, and especially the film actors who have died at a younger age, all because of the marijuana or cocaine. And people think that, oh, he was so healthy, they were taking care of their health, they were going to the gym, why the heart attack occurred? That is because they are paying for the mistake they have committed. So the substance abuse can cause. And this, my friend Shiba, she was presenting the young people, 19 to 20, 30 people, all coming with the sudden heart attack. And she has seen that, you can see that they're all drug abusers taking opium and multiple substances, and some Red Bull and Red Decold, and I don't know what it is. And all these things, have become fashion among the youngsters, and that is the one which is causing the heart attack and the sudden death among the youngsters. And apart from that, the stress is the most important. And stress, leads to multiple problems like increased blood clotting, increased blood pressure, poor digestion, and the increased hypercholesterol. And that's how, our Samskrita Subhashita says, Chintayascha chitayascha bindu matram vishishyate. Chita dahati nirjivam, chinta dahati jivanam, kintu vyatyasaha adhikaha bhavati. That means the difference between chinta and chitta is only 1 0. But that zero is very important, because the chitta burns the dead bodies. The chinta, or the worry or the stress, it kills the living person. And that's how we know today, because of the stress junkies, our youngsters are not sleeping, and their screen time has increased, and the sleepless nights are there, and they're playing the video games. And as a result, the lack of sleep also is causing the heart attack and the sudden death. And this is very important, and especially if less than 3 hours of sleep can cause the heart attack. Now, prolonged sitting in a one place, that also is a cause for the heart attack. So, lack of sleep and the lack of activity, both are killing the youngsters. And that's how we know it reduces the blood flow, impairs the endothelial function, disrupts the metabolic process. And that's how we know the weight gain is the worst thing. And mechanism of the heart attack, due to the lack of sleep, the hormonal imbalance, inflammation, and elevated blood pressure and heart rate, and the electric activity, all the mechanisms are shown. And that's how we know many people, the whole night they are partying, whole night they are spending with the mobile or their laptop, and the screen time has gone to almost 12 to 18 hours per day, and they are dying suddenly. And nowadays, the type A personalities have increased. They are highly motivated, ambitious, driven to succeed, natural planning, and they are always, agitated, and they want to go ahead pushing all others. And this type of type A personalities, they get into heart attack. So this is the Takatsubo syndrome, or a cardiomyopathy, first described in 1990 by the Japanese. The Japanese who built their country after the Hiroshima Nagasaki bombing, they were living for 110 years. But somewhere in the 90s, the youngsters started getting admitted to the hospital with almost looking like a heart attack, the symptoms. But when they did the angiogram, the coronaries were normal. And when they did the echo, you can see that the heart, was the left ventricle was dilated and it was so big, it was almost looking like a trap for the octopus. And then, hence, they called it the Takatsubo. And since the coronaries were normal, they couldn't do angioplasty, they couldn't do bypass, they had no idea what to do. And then when they analyzed, they came to know that all of them, they have so much of negativity, so much of frustration, so much of anger, so much of depression, and all that was causing the increased catecholamines and the cortisol, which was causing the coronary spasm and causing the dilated ventricle. So what they did was they used the Mahesh Yogi's transcendental meditation just for 20 minutes, and within 72 hours, the heart pumping, which was ejection fraction, which was just 15 or 20%, it becomes like 50-60% within 72 hours. And that's how, the whole world started looking at the yoga and dhyana. And that's how, today, Omkara, when it is chanted, it has a very calming effect. In fact, it has been studied in NIMHANS in Bengaluru, that the schizophrenic patients, when they were asked to chant Om at least 20 minutes every day, the blood supply to the limbic system came, and their negativity and their knee-jerk reactions and the anger and just rage, everything came down considerably. And they showed in the CT scan that the blood supply to the limbic system comes down and the negativity comes down. So today, the pranayama, it prevents the stress, it helps the digestion, and today anxiety also comes down.
Dr.
Today,
Vijayalakshmi ji,
I'll conclude.
time,
I'll
yeah.
conclude. Yeah. So air pollution is causing, and then the noise pollution. This is very important. The high decibel one, they're dancing for the DJ, and they suddenly fall dead. And all because all this has to be controlled. So today we have brain, heart, and the body access. And best thing is to children should not frown. They must learn to smile. The happy chemicals are very important, and the health is in there. So remember, we have PTCA, we have transplant, we have bypass, we have anything, but all this thing doesn't work unless we change our lifestyle. And the roots are the yoga and the meditation. So here, prevent smoking, spirit, stress, and sudden habit, and sleeplessness. And that's how we say Jaisa and Vaisa Man, Jaisa Man, Vaisa Tan. So thank you very much for your kind and the patient hearing. And the newer generations should realize that the old method of ethical living and happy living and contented living is more important. And that's how the tan ke tandurusti ke liye healthy heart and the wealthy mind is very important. Thank you very much.
Wonderful,
you.
Dr. Vijayalakshmi ji. I think a big round of applause to you. It was such a holistic approach. And I think it's very important for our pediatricians, because we see only tiny babies, but adolescent health chapter looks at big children and up to even 20-24 years. So we really wondered what we can do. So I think through your session, we came to know what are the common causes of sudden cardiac deaths, and how we can talk to the young people and what aspects we can counsel. And it was so complete. The approach was not just mixing yoga, meditation, substance abuse, sleep, and no stress. All these things were wonderful. Dr. Sudhir sir, over to you.
Thank you, ma'am. Wonderful. I would say complete presentation. Complete presentation on
Somebody's
sudden
talking.
cardiac
Can we
death.
mute them, Dr. Arya sir? Sharma sir, thoda mute कीजिए ना.
இல்ல அவன் வரணும் சொன்னா நீ போன் பண்ணா இல்ல எதுக்கு வீட்டோட கன்ஃபார்ம் பண்ணிட்டு வர சொல்லி சார்.
Are you the host, sir?
Please mute everybody else. Thank you, ma'am. Thank you for the wonderful presentation. Now I invite Dr. Nitin Rao to moderate the panel discussion on
Vijayalakshmi
cardiac
madam,
problems
please
in
be with
adolescents.
us through the AHA, I also invite all those who are here today. I would love to have you on lifestyle and other things, and if on social causes. To the meeting. Thank you from my side too.
And Himaben, ma'am, the question: Are we
Dr.
recording
Nitin
this?
Rao. Yeah.
Yes, ma'am. Yes,
Is this
Dr. Rao.
being
It is
recorded?
recorded.
All
It
right.
is being recorded.
Yeah,
Okay.
it is being recorded. We'll be posting the recorded link also later.
All right. Okay.
Yeah.
Thank you. I must thank Vijay Lakshman for a comprehensive look at cardiovascular problems affecting all of us. It's a very good introduction. Thank you so much, madam. And we had Hima, ma'am, do we have about half an hour for the panel discussion?
So you please go until 10:30. Yeah.
Yeah,
Right?
40
Yeah.
minutes or so.
40 minutes. Yes.
So we've had a very good start. So I have a very good panel here. We've got a panel discussion. I'd like to introduce my panelists. We have got, first of all, Dr. Smita Mishra, who's the HOD of Pediatric Cardiology at Manipal, and has many feathers to her hat. She's, in fact, one thing she's not mentioned. She is actually the brains behind getting insurance for patients with cardiac heart disease.
Yes.
We are all from Pediatric Cardiac Surgery IP are very grateful to her. She's been very active. In fact, one of the first FNP pediatric cardiologists in our country. And she comes from a cardiac family. Her husband is a very established cardiac surgeon. So great to have you. And we are going to have her points with us. Welcome, Dr. Smita.
Thank you so much, Dr. Nitin, for great introduction.
And Smita has not been well, but she's still on the panel. So that's the enthusiasm that she has. Very good. Thank you so much.
Thank you, sir. Thank
we
you so
also
much,
have Dr. Anamika Jain with us.
Good morning. Good evening. Yeah, good evening.
Anamika is a very senior pediatric cardiologist. She is at Jaipur now, and she has trained
Yes.
at AIIMS at Nara Rudayalaya, one of the senior pediatric at Jaipur. So very few in Jaipur doing pediatric cardiology. So it's very good, good to have her around.
Thank you.
We have Dr. Shikha Swarup also. Is Dr. Shikha there?
Good evening, everyone. Yes,
Yeah,
sir.
good evening, Dr. Shikha is a senior pediatrician from Jamshedpur at Tata Hospital. She's been sharing all her insights, and she has a great practice. She's there. Good to see you, Shikha. And we also have Dr. Lingaswamy, who is a pediatrician at Hyderabad. He is one of the youngest in the child. He's done his MBBS from Kurnool and his DM cardiology from Amrita in Cochin. He's now here. He started the pediatric department, AIG, new department here. He's doing very well. Good to have you, Lingaswamy.
Thank you, sir.
Is he
Thank
around?
you, sir.
Yeah.
Yes, sir.
Okay. So having said, can we go ahead?
Yes, Dr. Nitin Rao. I would like to add one few words about Nitin, and he's one of the very few, pediatric cardiologists who used to come all the way to our Institute of Child Health, Nilofer, just free of cost services. They have social bent of mind, and they used to extend services to our government hospital at seeing tiny babies. Thank you, Dr. Nitin Rao and Dr. Lingaswamy. Thank you for being with us today.
Sure. Thank you. Thank you.
So since we're talking of adolescent cardiology, and Dr. Madam has just said the mood for adolescent cardiology. We'd just like to, I thought what she has already talked of hypertension, diabetes, metabolic syndrome. We'll just elaborate on these small things, how much in the time we have. And one thing I always felt, and one thing what Madam highlighted is the importance of hypertension. Somehow, in fact, we don't look at hypertension so much, though we should be having. So I just like Anamika, how common do you see hypertension so common in practice? Is it really so common? Is it increasing nowadays? Are we more aware? And do you see it in all age groups, or is it more in adolescents that you see?
Frankly speaking, we are seeing little increase in the numbers. And as the studies and all, they quote that in 2000, year 2000, it was around 3% or something in the general in the adolescents, but now it has almost doubled. So in the last 20 years, it has doubled, and thanks to the lifestyle and the unhealthy diet habits and the obesity and other things which are there, high sodium content diet and all those things which are causing this increase in the hypertension. So overall, yes, definitely it is increasing in the adolescent group because of the obesity part, which is also increasing, and physical activity reducing and all those factors.
Yeah. Do you see it in rural and urban patients?
Apart from that, no alcohol consumption, That is a
Yeah.
single important one. 20% of those people, they develop hypertension.
It is being translated
That's
for AI
there.
companion.
Yes.
Yeah. Yeah.
Yeah.
And they see it at home as well.
Unless somebody shares. Yes. Within will share.
Yeah, so they develop from home as well. So Anamika, do you see a great amount of hypertension in urban areas or rural areas? Is it the same, or do you see more?
Definitely, it is more in the urban areas because the social impact of mobile and other these lifestyle has not still penetrated so much in the rural areas. There's a little differences there, but definitely urban areas it is more. The peer pressure and all those things, especially in the adolescent age group, because it's a developmental phase, all the hormones are changing, their image consciousness and other things they are have increased, and all even children with other cardiac symptoms like chest pain and syncope, they have increased much more, especially in the last 5 years
Yeah,
in our
like
daily
Dr.
practice.
Vijayalakshmi was saying that all these lifestyle changes are more common in urban than rural. So you're probably seeing one.
Yes,
And
yes.
but I still feel BP is probably happens probably underreported in areas more rural than urban. It's probably much more than we actually find out, right?
Yes, yes, definitely.
And
Even the patients who are coming to the hospitals, 95% of the hospitals, especially the pediatric hospitals, they are not measuring blood pressure. Even I will say 95% of the cardiologists, pediatric cardiologists, even though we are saying very good things, but still in practice, we are only measuring blood pressures in a very convenient patients, and those high risk patients only. It is not an automatic systematic thing that is happening. So we need to change that habit in our clinics and get it done as we get it done blood pressure, height and weight checked, outside or near the reception. The same way blood pressure should be done. Then we will know the real picture.
so should we make it mandatory like we take saturation for all? So we should do that probably, right?
Yes, yes, definitely. It
Yeah,
should be done.
I fully agree with Anamika because most of the time, the blood pressure is not checked with the proper cuffs. And that is how they missed. And the pulse is not felt. So coarctation of aorta, aortoarthritis, then renovascular hypertension, all of them are very common among the children and the adolescents, and that should not be missed.
And like Animika said, we should do that. I'd like to share it was my own case. I had a child I was seeing from the age of 6 months, and we are saying dilated cardiomyopathy is not doing well, not doing well. I got multiple imaging, it was all right. Then, but BP was borderline about 100, but finally I did an ultrasound abdomen. First I was normal, second I showed a small chronic contracted kidney, basically non-functioning kidney. So I underwent a nephrectomy, he did well. So this was, I mean, I should have checked at 6 months, but it
Dr.
never happened.
Nitin
So
Rao,
yeah.
instead of sending that patient for the nephrectomy, we can do the coil closure, embolization of the renal artery. And that is much safer and much more efficacious.
So the really chronic contact is very, very small kidney. So that's the reason we send that. And he had LV dysfunction as well. That's the reason. Yeah.
Yeah. And one important thing, like Dr. Vijayalakshmi pointed out, feeling the pulse. It is so important, such a simple thing.
Yes.
Recently, we had in some hospital, there was a patient who was admitted as a dilated cardiomyopathic severe AR, and they said he was in hypertension. So all the adrenaline and vasopressin, all those drugs were being started.
Must have
because
been
they were measuring,
aortoarthritis.
they were measuring blood pressure in the hands only. And I went for doing the echo. So when I touched the feet, there were bounding pulses. I said, how come this BP is being shown and lower limbs have this thing? So it was a Takayasu arthritis, totally managed in the opposite way. So we reduced all the hypertensives, started other drugs, and now the child is better.
And
So
was there a
this
good
is
urine
important.
output? Was there a good urine output?
No, the LV was down just 20%. So
Yeah,
it
because
was like that.
that's a clue.
And
Suppose you've got absent pulses but good urine output, that means there's something wrong.
so no, this patient was having unusual presentation because both the upper limbs were blocked, and even neck vessel. He had a first presentation was a stroke, then the upper limbs gone, but the lower limbs were still little bit maintained. So that is why they just missed it.
Takayasu.
Yeah, Takayasu.
And remember, when you do find these hypertensives, when you start them on drugs, do they comply? Do adolescents comply? Is it difficult?
It is difficult.
Yeah,
Initially,
especially school
to
going.
start also, the family and the patient doesn't really, get
Understand.
very motivated to start. They try to delay the things. And once even they start, then because of the college or school schedules, it doesn't fit regime. So because they have to go to washroom, other things, or even taking medicine in the school, they don't find it, very convenient. So it is difficult, and they, after few months and all, they usually, stop by on their own. It is very common.
And do you see a lot of renovascular hypertension in yours? Have you seen lots of them? To the question.
Renovascular, yes, in the younger age groups, we find more of renovascular hypertension. And in the older age group, with the Takayasu arthritis, it is more common, renovascular and other involvement.
And Takayasu, you can have above or below the renal arteries, and both the renal arteries may be
Can
same.
be
And
fired,
apart
can be
from
fired.
that, the coarctation is missed. So I had one patient with the mitral stenosis. Patient was put on the table with the atrial fibrillation, pulmonary edema for the balloon dilatation. And the moment I painted and felt the pulse, it was not there. And I told my professor, sir, this is coarctation. He wouldn't believe it. But then I said, I'll take the bets, it was coarctation with the mitral stenosis. So in our country, any combination can be there. So proper examination, feeling the pulse and recording the blood pressure is a must for every child. I say, be Indian, touch the feet, and you'll never miss the coarctation.
Yeah.
Yeah. Dr. Shika, what do you think? What is your experience on hypertension that you've seen in your setup?
Sir, ideally we should take BP of all the child, which is recommended. But again, it is difficult in a busy OPD practice, especially for a general pediatrician who is seeing a
Right.
lot of patients.
Right.
So, like I make a point whenever I see a overweight child, I take a blood pressure. And once parents were also surprised to know that there was an adolescent girl and she was overweight. And when I took a blood pressure, it was coming very high. And I also, she was completely asymptomatic. So I also thought that maybe she's anxious because she's in a clinic. And then again, I told her to calm down. And again, I took a repeat blood pressure. And again, it came on a higher side. And it was very difficult for me to counsel parents that she needs monitoring and other things. Means they were not believing that how she is asymptomatic. See, they came for just a general checkup like fever and cough and cold. And she was having no symptoms, no headache, no nothing. She was very comfortable, only overweight. So, taking blood pressure is very important if we need to screen and diagnose such children early before the complication arises.
So did you start on the hypertension?
I fully agree with Shika because a 42-day baby with a 220 by 120, my associate was scared to raise the cup, and they were putting the inotropes in the medical college. So without recording the BP, without feeling the pulse, and just because dilated LV is there, the child is in failure, and putting on the drugs is wrong. I think Shika is 100% right. The BP has to be checked because it's a silent killer and the symptoms will not be there. And by the time symptoms come, it will be too late. And that's how we have to educate the parents and the pediatricians also.
Yeah, and every case of seizure should have blood pressure checked and ECG done. Every case of seizure and syncope, that should be mandatory.
Yeah, the child of yours, Shika, the one you start, the obese child. Were you able to start medicine, antihypertensives? Did they take?
Sir, I wanted to actually admit the child and monitor the blood pressure because I asked him to come to follow up so that I wanted to confirm that she's not anxious or any acute condition is not leading to this
Yeah.
hypertension. But I think they didn't turn up to me again. So I lost follow up of that child.
Then do you see, Dr. Vijay has talked about diabetes and metabolic. Do you see lots of children there? Rising incidence of type 2 diabetes in Jabalpur?
In Jamshedpur, sir.
Jamshedpur, yeah, sorry. Do you see
Sir,
that?
in Jamshedpur, I have not seen type 2 in adolescent too many. Still, we are seeing more of type 1. More of type 1 are coming to us in complicated, like is the common typical presentation of diabetic ketoacidosis. But obesity, yes. like very 10 year, 12 year, the lifestyle has changed.
Yeah.
As ma'am already said, they are eating processed food, junk food,
Yeah.
and they are not playing. They are not interacting with their peers. They are spending more time on the screen. So these two things are epidemic, like screen time, playing video game instead of outdoor games,
Screen time, yeah.
and the food they all have this habit since childhood. Like they have chips. Anybody comes to home, they will hand the chips packet or kurkure packet, and then they become habituated of it. So they
Yeah,
don't
trans
like
fats.
other food. They
Trans
that
fats, yeah.
doesn't taste
And
good.
Shika, you know, when they eat like this, you know, they can't eat food. And one father had brought a child, you know, it is 8 years old child, and they said, doctor, he's not eating anything. I said,
कुछ
why is he not
कुछ भी
playing?
नहीं खाते हैं.
He plays a lot. What games he plays? Video games he plays. So with the video game, how can he have the appetite and eating junk? That is the
If screen time and junk food is epidemic, it is very common. It is not rare, or it is very common. So soon we will see cardiac disease, metabolic syndrome in large number.
So I
If this
think,
doesn't change.
Himabindu, this is the point for you people to, when you go to the schools and colleges, you have to stress on this point.
Yes, madam. We are speaking about metabolic wellness in our youth wellness initiative. And this is our flagship program this year.
Yeah. So in continuation of this, suppose you have diabetes, should we do a lipid profile on them? It's a question to all panelists. Should we do lipid profile?
Yes, sir, we should. When we diagnose a diabetes, we should do at the time of diagnosis, and we can repeat it again in 3 monthly, and annually checkup should be done. Because if LDL is on higher side, it can have a long-term effect on coronary arteries and other complications.
So there was a question, someone is, when will you start statins in LDL in a child? You would like to start immediately? You would like to wait? What would you like to do? It's
So
LDL, it's not triglyceride, yeah.
we should first treat diabetes, and then on follow-up, we can see the lipid profile. And if it is still on higher side, we can consider.
Dr. Smita, what level would you like to start LDL?
Around 130, but actually diet
statin.
regulation remains the first thing, because
Yeah.
it is not only about the diabetes. It's not always with the diabetes, but lipid dysregulation is more common than the diabetes. So lipid profile, if a obese child, or particularly a child with the chips in hand and the video game in front, probably should we definitely look for the and the other thing, because internationally it is seen that hypercholesteremia, heterozygous or homozygous, is common, and it's a region for the premature CAD.
Right.
So lipid profile is actually being kind of cascade. This thing is screening, so it is being prescribed like that.
So would you like to start statins at LDL 130 or 160? Or what would you like?
130,
Suppose repeat lipid profile 3 months is still the same. So 130, what would be cut off?
130, right.
And since we talked about Dr. Vijayakshmi had talked a lot about coronary artery disease. So what is your there's more of CAD coming nowadays, and what is your view on the CAD in children in the Indian context? What do you think?
See, basically, Indian children are very predisposed. It's a very interesting study recently published in 2024 in Lancet. So they have found that Indians are actually a decade, they have CAD a decade before the other Western counterpart. And that all being related to the maternal health and the birth of the child and the perinatal care and everything in the infancy. So they say that these are the little fat babies, the infants they are called as, because their muscle content is less and the fat content is higher. So we need to actually, that is one part. So the first myocardial infarction case you may get, or a case coronary artery disease is the L-kappa if there is a congenital heart disease. And the second coronary artery disease, which is very common in infancy, I can only recollect one patient which was operated by Dr. Bhan, and it was infarction and 17 months old child. And there are certain other my counter pediatric cardiologists have shown this series where there was a serious coronary artery disease which needed some intervention. But these cases were never belonging to me. But first case of my life of the Kawasaki disease, who expired in the 5 to 6 hours after the diagnosis. This case was treated as a case of some other infection, fever with rash for 15 days with the antibiotics. When it came to me, I could see the large aneurysm, and we could not do anything because within few hours this child died. So we tried to report also this case in 2007-8, but it was not accepted. So there are many cases, such kind of cases where Kawasaki related disease coronary artery disease hasn't been reported. I think so. Then the hypercholesteremia, familiar hypercholesteremia, what Dr. Vijay Lakshmi showed, that is another reason for the premature CAD. Then if you leave apart everything, then we come to comprehensive national survey, nutritional survey, which actually shows what Dr. Shikha was saying, that increased incidence of the hyperglycemia, hypertension, and obesity. So these are all substrate for the CAD. So we should keep a close watch, because nowadays children are having smoking. They are also smoking, and they are also having cocaine it's a very common thing. So definitely they are quite prone. I don't know any related deaths, any incidents, any prevalence. I don't know if it has been published as if now. Then other thing are like the polyarteritis nodosa, aortoarteritis, what Dr. Vijay Lakshmi has actually said to us, and then chronic kidney disease, then cancer survivors. These are the cases which may present at any time with the coronary artery disease also, and cardiac dysfunction. Then the sickle cell disease, that is another, because thrombotic incidents may cause coronary artery disease. Then I think these are the substance abuse that has been talked already. So these are the things which may cause and all these factors are actually, you should never forget that these are the genetic epigenetic factor which will ultimately decide that CAD will happen or not. So that is also very important, that genetic background we must know.
Can you see the slide of CAD substrate?
Yeah, yeah. So you have said these are all the diseases, and I have written this genetic and epigenetic factors, which are obviously very important. I think I am going to write a paper on that, coronary
Very
artery
good.
disease, and because why there are many patients in COVID-19, they had coronary artery disease subsequently. So that is, there is a strong correlation between the epigenetic factor being altered by the COVID-19 virus. Yes.
Yeah. So are we seeing more and more Kawasaki nowadays? Like you said, the first patient was the one who died. That was in
That yes, so
2007.
Kawasaki disease became, because we actually published a series also in 2011. So Kawasaki disease, as we know, is a benign disease relatively. But if around 25 to 40% cases may have coronary artery involvement, there you need to be very vigilant that it is there or not there. These cases again, there is a genetic predisposition, and we see more and more patient in the Southeast Asian country like the Japan and area around. And these are the genetically predisposed population, which is even in US makes the most vulnerable population for this. So this is very important. And I think what else in this question, Dr. Nitin?
Yeah, I think what you said is the geographical factors matter a lot.
Matter a lot.
There are a
And
lot of literature saying aneurysm from Japan and Taiwan, but our instance is not so much. And the one
yes,
we've seen, they have actually come down over time. We rarely had patients who had this. So the
ah,
incidence of MI is more that side.
that side, yes.
Yeah,
In
Dr.
fact, I had,
Nitin,
yeah,
yeah, I think post-COVID, even the Kawasaki the presentation of Kawasaki has
it's
taken a
changed.
drastic change.
Yeah, it has
Earlier, it
changed.
used to be more of aneurysms, but now it is more of just general dilatation and,
Right,
more prominence, which
right.
responds to IVIG
Exactly,
and
exactly.
steroids, take them
Yeah,
drastically.
right.
So it has also changed its, presentation, I think. And it has become more common now.
Yeah. Now, I had a patient, a Telugu patient from Andhra Pradesh, but they were staying in Japan for some time. The child developed Kawasaki there, and the child had giant aneurysm, which I've never seen in our patients actually. And we followed up, and then later on, the father went to Netherlands, so they had an MI there. The 7-year-old and the child entered CABG. This was one of the youngest patients who had this. Most of the patients have been okay, but this is very rare. So I feel like Smita, like you said, epigenetic factors probably play a major role in this. So the variants that we see here probably milder. They survive much better. That's my presumption. I don't know.
Yeah, yeah, yeah.
But Dr. Nitin, I have seen many patients here also having the giant aneurysm.
Yeah.
And one of my patient is from Afghanistan, and this is the girl having the large aneurysm in this circumflex artery, which is very rare, in fact. Mostly we see LAD and RCA, but in this particular case, all RCA, LAD, and the circumflex having the giant aneurysm. And it's not reducing more. I am just keeping on the all these three drugs and anticoagulant like warfarin also is added for that baby. So we don't know. I got a patient from Chhattisgarh long back in 2009. So this patient had a PFO, and patient was sent me to assess for the ASD device closure. And I was so surprised that a small PFO was noticed, but the large aneurysm was not noticed.
Yeah.
So that was the case, but there was no inflammatory marker positive, so there was no role of IVIG or steroid or anything. Because once the inflammatory markers are down, the any anti-inflammatory treatment is not required at all.
So if you have a child with aneurysm like this, what you'll give antiplatelets, anticoagulants. Lots of
Yes.
patients are giving statins as well. What do you think?
Statin is like when I was reviewing this for an international publication. So statin is a good because even if the aneurysm regress, because the method is actually formation and clot and recanalization. That is how it regresses. So part of wall is made of the thrombus, not exactly the cells. So there is a endothelial dysfunction, going on. So that's why statin is a good idea.
Yeah, and one thing, this coronary artery and Kawasaki never rupture because they are usually thick walled. Atherosclerotic may rupture, but the coronary artery aneurysm rupture is very rare. So that's
Very rare, but it is reported. It is expected in if it is too big.
all right. Now, Smita, suppose we have a child with coronary arteries Kawasaki who's on follow up, and he comes back with fever, rash, or he comes back with chest pain. How do you go about? Because now
Uh,
parents are very educated, they do Google, so they are very upset. So how do we counsel them? Because this is a recurrent, this is going to come now, we are seeing.
Kawasaki disease coming with the chest pain.
Yes, yeah.
See, our review should always be including, because one thing is one should always remember that Kawasaki disease will cause also coronary artery stenosis, which remain undiagnosed.
Yeah.
And coronary artery aneurysm are very well diagnosed, but not the coronary artery stenosis. And that stenosis is more dangerous. So the thing is, every examination, echo examination, should contain we should see that regional wall motion abnormality. That is very important. The second thing, if it is a little older child, like 10 years up, they should go for the stress test modified Bruce protocol. And the thing is, the parents should be given this thing, the risk of Kawasaki is this. I always advise to go for CT angio. It is not written everywhere. People will say no, but I will definitely advise for the little older children where I cannot see the peripheral coronary artery. And one of my patient, I continued on the aspirin up to 10 years of age. The first diagnosis for the Kawasaki disease was made around say 4 years. Then I was able to see the coronary artery very well. Child became very fat, and then subsequently the visualization of coronary artery was poor. So it was whatever the higher side of Z score, not exactly in abnormal range, but I kept a very strong suspicion. And because I was sending this baby for the CT angio, and because of heart rate, it was not possible to go for CT angio. CT angio, then subsequently, because of reluctance of parents and all, it was done at the age of 10 years, and there was an aneurysm sitting on distal circumflex artery. So you should never be sure while you are doing echo examination that aneurysm are regressed completely.
Yeah.
The Nitin
But-
Lingaswamy is also here, na? I thought, yeah.
Yeah. So, yes, yes, Lingaswamy, we talked of this. I just want to ask you, like we talked of coronary disease, we get a lot of referrals, especially adolescents. Yeah, you see a lot of patients coming with chest pain, palpitation, syncope. I see it very common in young adults. I mean, adolescents. We get a lot of referrals. There's a lot of parental anxiety, pediatrician also quite. So, do you see that common? How do you go about a child comes with chest pain?
Yeah. So as a pediatric pathologist,
Lingaswamy, you're on two devices. You need to mute one. Hello?
One second.
Nitin, we can come out of this PowerPoint.
Okay.
Actually, you stop sharing PowerPoint. I don't know. Thank you.
Right.
Lingaswamy, I cannot see him.
Yeah, he's there. He's there. Smita, do you see the recurrence of Kawasaki? Have you had recurrence?
Yes, definitely. So, particularly within few days. So,
Is it common? I find it's common in the infants. That's not true, but I've always found the infants have it
no,
more.
no, I have seen in
Old age.
below 5 years in 3-4 cases, we had to give the infliximab, responded well. One thing I want to mention over here, that sometimes the IVIG is not affordable at all. And in that case, we should definitely try steroid, though the studies show that the aneurysm formation in steroid is around 6.2% vis-a-vis IVIG 2 point something percent. So maybe 6.2 whatever for the steroid, but it may be useful. Still, it's a very useful adjunct to the resistant Kawasaki. So
We
if
use a lot of
one
methylpred
can,
with IVG has done very well actually.
now, one of the cocaine analysis that also says that these two drugs can be started simultaneously if risk factors are there.
Yeah.
Yeah, Lingaswamy has come back.
Yeah. Dr. Lingaswamy?
Dr. Lingaswamy, you can speak with your video off. Problem.
Yeah. You're mute. You please unmute yourself, Lingaswamy. You have to unmute.
You are muted, Linga.
Yeah.
Yeah, now.
Yeah, now very well. Now very well.
Okay. So as a pediatric, is a secondary.
There's echoing going on. You need to, I think you're on two devices. Can you just
Yeah, now is okay.
Yeah, now better, much better.
Sorry for. So as a pediatric cardiologist, I am regularly seeing almost like 20 to 30% cases as a pediatrician from the pediatrician as a referral as a chest pain and syncope. So when we saw this, is a parents will get first thing is it's like a heart related problem. So then because of the problem is because of nowadays the burden of lifestyle related diseases are increasing. That will be the mainly manifested as chest pain. That will be the parents will become anxious, and the children also become anxious because of that. Is maybe because of this heart related issue is the major concern. But fortunately, the problem is only less than 5% of causes of chest pain is because of cardiac related. Almost like 40 to 50% of causes of chest pain is mainly non-cardiac is the major concern, like costochondritis, like respiratory diseases causing that mainly chest pain and trauma related things, and they're carrying the heavy bags whenever they're going to the school, and muscle strain lifting of something like heavy things. So that will be the major cause for that. Is the major thing. Non-cardiac is the only less than 5% is the major cause for that one. So whenever we see that any patient with the chest pain came to our OPD, first thing is thorough history and general physical examination we go ahead with. First, whenever we ask the history point of view, main thing is characteristic of the pain, how it's happening, when it's happening, and also is it associated with exertion, any associated symptoms, palpitation, syncope is there, is it causing the immediate sudden onset, is it radiating to back? That will be the characteristic of pain will determine that is it related to cardiac or associated with the cough, any post-viral illness, that is after having the cough, cold is having the pain. So these are all the things we will go ahead with the basic history point of view. After that, we have to be thoroughly asked about the is there any associated CHD, or you are regularly following with the any cardiologist or anything, family history of any congenital family history of premature cardiac death is there or not. We have to be thoroughly evaluated in this point of view also. If you go through this one, like any family history of premature cardiac death, then we can evaluate further with them. If any red flag signs you are seeing that exertional chest pain and also the associated symptoms is there, family history, premature cardiac death is there, then we can further evaluate with the ECG and echocardiography. If need, we have to do the exercise testing, especially if there is a family history of cardiac death is there, familial hypercholesteremia. These babies will have to go ahead with the evaluation of lipid profile, and if there is a very family history, genetic history, we have to be evaluate these cases. Frequent follow-ups of these, periodic follow-up every even though not having the any symptoms noticed, we have to follow up these children.
Yeah, we also get referrals for like you said, for the family stuff, premature C8 in the family is there. Then you have to be much more careful, because we got a patient last week. The father had passed away at 28, so mother was very very upset. But it like you said, you have to be much more aggressive when you have this family history. And what you get some adolescent syncope also, isn't it?
Yeah. So one of the another thing is chest pain. Apart from the chest pain, syncope is the very worrisome to the especially the parents. This is because very difficult to get the elicit the history, because it's happened in the somewhere, maybe the school, somewhere they are getting that type of episode. The clarity of the scenario is very less on that one. But we will get lot of these things of syncope is very commonly nowadays. So when we go through that one, always taking the history. Syncope is most of the cases is a clinical diagnosis. So no need of further thing of doing of unnecessary investigations. First take of the thorough history is very important. So what makes the patient child will be the going into the vasovagal syncope. What is the event is happening? Before the event is happening, how is the posture of the child? Is there any prodrome is happening? How the event is gone? And also how much is the time for recovering of the child. So if these type of the things are there, then it's like a classical, generally we'll see that one in the prolonged starving, like morning breakfast is not taken, and also this summer season and some emotional stress during the exam period time. So these type of the things will get is the generally this vasovagal syncope. For example, if any patient will having the syncope during the exertional time, so it means that it's definitely is alarming, and it will be these cases will having the cardiac type of the things. If associated with the palpitation with the syncope without any prodrome, it's happened suddenly that one. and also family history of any cardiac death is there, especially in case of the syncope. These patients, we have to be evaluated by the pediatric cardiologist thoroughly with the proper ECG, 12-lead ECG, to rule out any long QT syndrome is there, WPW syndrome, heart block, sinus pauses. These are all the things we have to. If need further echocardiography to rule out any structural things are there or not, Holter, if need tilt table test, if you're not able to. So in my routine clinic, any patient with the chest pain and syncope, we cannot rush to do the, always do the thorough history, then take the 12-lead ECG. If anything is, then it will make that one 95% of cardiac causes will be ruled out if you evaluate history, general physical examination, and the ECG. So we will give further, we will evaluate if this is like parents are so much anxious, if we are strongly suspicion of cardiac thing, then we can further evaluate with others like further exercise testing and also the echo and Holter. These things we can go.
Suppose there's a family history of HOCM.
Yeah.
And the child comes with syncope. How aggressive will you be? Would like to investigate all family members, take a genetics. I just want to have a scenario.
Any child with the HOC, family history of HOCM, so there is like we have to be do after 12 years of age group. Generally, there is a criteria for to do other family members when to screen if the child is having the unexplained syncope is there. But if either asymptomatic, we will be closely follow up the children. After 12 years, we will need, if need any episodes of syncope is there, any like palpitations to the child, and also the any echocardiographic suggestive of left ventricular mass is increasing, septal diameter is more than 12, then we will go ahead with the genetic screening of the that family members. If need, then we can go ahead with that.
All right. The reason I'm asking because I have a patient in a family where three of them have HOCM. One patient also had an ICD because of palpitation for arrhythmias. And then the one of the ladies conceived, so the fetal liquid was normal. Baby has developed normal. So very strong families. So we need to be much more careful in that.
Yeah, correct.
Yeah, Madam Himabindu, do we have some time or?
We should wind up now with some key messages, Dr. Nitin. We had a wonderful discussion.
Before we wind up, I just want all the panelists to talk on rheumatic heart disease. We've not touched it. We did short of time. We are seeing much less there, but it's still there. What it was 30 is not there, but it's still a very much part of our clinic. Just a take on rheumatic heart for all of you. Shika, what do you think? What do you see?
Sir, I'm not seeing it as much as we used to see when I was doing my own residency.
Right.
So definitely we are seeing less number, but we cannot say that it is not there. Still, we have the streptococcal infections are still there, though amoxiclav treatment is commonly done by the general pediatrician and antibiotic is easily available. But still, it is there, though I think that the prevalence has decreased.
Had this
You
classical
don't see the
cases in a
malignant
long
carditis that you
case
see
and short
nowadays.
case during PG days, examination.
Exactly.
Traumatic heart hackening.
I know. But you're not seeing the florid carditis that we're seeing earlier.
Such cases we are not seeing so much as I used to see during my PG times. Classical cases, all the findings and such cases. So most of them present later, sir, with already having heart disease.
Yeah. How about availability of pennies? Do you find Penidure? A lot of patients complain that they don't get. Anamika?
Yeah, it is difficult for them to get. So they keep the whole, bunch of it for the एक साल का पूरा उठा के जब भी मिल जाता है रखते हैं.
Yeah, and one thing I find is not many, they don't do sensitive testing. I asked all, they just given the without testing. That's very bad. So I write on notes, but I tell the parents not to give unless the testing is done.
Nitin, I would like to, like I was the convener of this rheumatic heart disease NARF consensus meet.
Right.
So I actually researched on the sensitivity testing.
Yeah.
And the thing is, because Penidure website said that it should not be given subcutaneous or intradermal, this benzathine penicillin. So I really tried to find out why, because mostly we were giving in our medical college days sensitivity,
Exactly.
diluting the benzathine penicillin and giving it intradermal or subcutaneous. So I went through all over world actually. I have written everyone. So I came to know one paper from Odisha. So this article said about the minor and major antigen
Reactions.
which were supplied with the benzathine penicillin. So which they were not being supplied in India. So the thing is, the benzathine penicillin is a lipid soluble thing. So it is only 25% solubility. So if we want to make it 1 in 10, 1 in 100, we cannot make it because it's not soluble. So, and the other thing, because being a lipid soluble agent, it will not immediately be absorbed and when 15, what
React,
we
yeah.
expect within few minutes, that wheel reaction will not come. Even I got a paper where somebody said that after giving benzathine penicillin sensitivity test, 72 hours the wheel reaction was came. So it was very true because that website for the wire which was supplying the benzathine said that sensitivity may be shown because of this some impurity or some other content
In the drug,
being
yeah.
reactive to this thing. So that sensitivity which is shown is not actually for the penicillin. So then a Swedish person, immunologist, he responded. This answer what I am giving was given by him. Then one
Okay.
Indian from the some Toronto or somewhere, so she wrote that because these minor and major antigen are not supplied with the benzathine, then it should be they should give benzyl penicillin. Benzyl penicillin should be given for the test, and the
And
benzyl
then
penicillin is water soluble, but it has only minor this thing
react
antigen.
antigen.
It doesn't have major. So the patient then should be told that this thing like major allergen is not being tested because it is not available. But then other thing is being said that benzathine penicillin related death, they are not because of so much for the anaphylaxis as much is for the wrong
Yeah.
way of giving injection and the pain component, because the most of the time when we are giving benzathine to a sick patient, they are emaciated and gluteal muscle is not so much, and because the benzathine penicillin cannot be dissolved, so injection is very tough to give.
Very painful, yeah. The needle
There
gets
are a lot of
blocked
things.
most of the time,
So
yeah.
you just move your needle to push it again, and then you land up in the nerve or somewhere, and that is the pain which is causing the death. So these are the things which I found out at that time,
Yeah.
and I written in that the
Yeah.
2008 this was published. Yeah.
I agree, but I think you have to have one reaction to be wary of that.
Mm.
So you have to be
So,
very when you have, and
sir,
like
I
you
want
said,
to
maybe the wrong way of administering, because we once had a patient where the patient received IV benzodiazepine. There's no chance of survival. The nurse gave IV benzothine, so
Mm.
that's bad.
Nitin, can we have the key messages?
Yeah, yeah.
Sir,
You
I
can
want
have
to tell you one thing, sir,
yeah,
about
yeah,
rheumatic heart disease. There is
yeah,
a one entity called subclinical rheumatic heart disease.
right.
Nowadays, so we can't see that one, we can't hear no symptoms, there is a no murmur when you evaluate it. But echocardiographically, you can see that one, that is the entity we are missing nowadays. Even though rheumatic fever, like the incidence of the rheumatic heart disease has come down with the nowadays, but the subclinical RHD, if I saw like last 2 years back, one child, almost like 9 years, the child having that mild AML prolapse is there. So over a period of time, like minimal mild MR is there. Now it's now after 2 years, that is like thickening of the leaflets is happened. Then AML MR is progressed. So that we are that one is we missed the initial phase of that 1 to 2 years. That one once established, it will take some time. That entity we have to be addressed it now.
Very
Yeah.
good, Lingaswamy very nicely said. Because Dr. Anita Saxena's paper, 2 papers at 10 years, I think 8 to 10 years gap. So Najafgarh में उन्होंने किया था जो. So there was a decline in even the echocardiography diagnosed subclinical endocarditis. But still, if we lose our guards, if you don't see it properly and you don't try to find
You
out
can
that
miss,
there
yeah.
could be a rheumatic underlying cause, we may miss the bus. Yeah.
Exactly. Yeah.
Thank you,
Yeah.
Nitin
Thank you so
ji.
much. I'd like to just sum up.
Yeah.
It was a very good discussion. And this points on adolescent, we would like to go more, but covered very well. I would like to thank all the panel. And I just would like to say that this, Dr. Bansal said replace, when he talked about lifestyle and metabolic syndrome, he said replace kurkure with murmure. Salads and dry fruits the best fast food. Namak chini chiknai ka paresh rakhe. That's a very good message that came out. And uh, like rheumatic fever is on the decline now, but we still need to be aware. And the Jones criteria need not apply. You need to be much more liberal in diagnosing rheumatic heart disease. We are seeing many more cases of chest pain now. We are seeing coronary disease probably is going to be even much more. And we need to be aware, and pediatricians need to be aware of all this. We'll get lots of patients in the coming decades, but we need to be aware.
One more thing, Nitin, one of the American, this thing, amphetamine is one of the cause for the chest pain, which is being taken by so many students.
Yeah, yeah.
Thank you, Dr. Nitin and Dr. Vijay Lakshmi ji. It was such a wonderful discussion from our AHA on behalf of everybody. We really enjoyed it. And most of these points should be remembered by our practicing pediatricians when they see the adolescents and young people. Because we adolescents, मतलब हम सब लोग counseling करते हैं, lifestyle, mental health, and बाकी चीजों पे. But when it comes to specialities, we require a little guidance, and that's why we are conducting all the super specialty webinars. And thank you for all of your presence. Now, any doubts are there? Anything on the chat box? I think there are no particular questions there. But
thank you everyone for waiting. We still have 45 people on board at 10:45. Thank you so much. Very heartening to know you've been listening to us. Thank you so much. Thank you for your patient hearing, all of you. Dr. Hima, thank you so much. And Dr. Vijay Lakshmi, thank you for the.
Thank you, Dr.
I have 2 questions, ma'am, please.
Yes, sir, please.
One question. Yes. 2 questions for Dr. Vijay Lakshmi. I want to know the incidence-wise, 3 causes of sudden death in adolescent. Number 1 question. Number 2, the mechanism of vitamin D which causes sudden death.
Actually, I'm not able to see. Vijay Lakshmi ji, aap hai?
Any expert can give? Any expert?
Yes, sir. The commonest cause of sudden cardiac death is, first of all, even now, still arrhythmias. We still don't, we're still underreporting them, but I'm sure they're like long QT syndrome, like Dr. Vijay Lakshmi said, I'm sure it's more underreported. We don't pick them. Arrhythmia is still the number one. And now CAD is going to develop now. It's going to come as a big man. CAD is going to be there. And the third is genetic cause. There's so many, but I would say arrhythmias are the number one. And we don't take so many EC, we don't see so much, but we should be doing much more than we'll actually pick them. Which is why now electrophysiologists are becoming more, they are doing much more work because people are picking up things. So that will remain the number one for us. And CAD will also come up later. That's so. Sir, what is the second question, sir? Sorry.
Vitamin D.
Yeah.
Vitamin D. Mechanisms of action, vitamin D causing sudden cardiac arrest and cardiac death in the adolescents.
The vitamin D is absolutely essential for everything, no doubt. I'll tell you one case we had few years back. We had a physician refer to our hospital for as dietary cardiomyopathy for ICD, and it turned out vitamin D deficient. That's all. So vitamin D is absolutely everything. It's there in all systems, and we are underreporting them. So exact molecule I will not be able to. I don't know, but it's absolutely essential for everything.
Yes, my opinion and which I have seen in my practice. Vitamin D deficiency present in any way.
Anyway.
In any way. If you don't find any positive investigation or diagnosis, you must go for vitamin D.
Exactly.
Vitamin D primarily calcium metabolism
Yeah.
definitely altered, so you get kind of cardiomyopathy. Cardiomyopathy and cardiomyopathy predisposes for arrhythmia. So end of the day, the sudden cardiac death is always associated with some dysarrhythmia. And obviously, Dr. Nitin said the not only long QT syndrome, but the Brugada even is prevalent in 14 to 20 years of age. So one should look for this, and I think every child should be screened for the echo and the ECG right from beginning. I am one who actually suggests that one ECG will never harm, one echo will never harm.
Yeah.
Good messages.
And Sharma sir, yesterday there was a thing that 3 risk factors for Alzheimer's now is vitamin D deficiency, then chronic sleep deficit, and stress. So this come yesterday. So what pediatrics have been saying about vitamin D holds good. That's all.
Yeah, great.
Yeah.
So much to learn from all of you. So it's already 10:45.
Yeah.
So I request Sneha ji to please formally give us a vote of thanks. I think really nice to see Avinash Bansal ji and of course Sharma ji to interact with us in the late hour. Over to you, Sneha ji, on behalf of AHA to give the formal vote of thanks.
I
Art
extend
treasurer
my
of AHA.
I am Dr. Sneha Gadkar, Treasurer AHA. Extend my sincere thanks to today's speaker, Dr. Vijay Lakshmi. She has given her words of wisdom on this topic of sudden cardiac death. And she had told the measures also how to reduce it in a very simple way. I thank Dr. Nitin for conducting very useful and panel discussion with a very eminent speaker, Dr. Smita Mishra, Dr. Anamika, Dr. Lingaswamy, and Dr. Shikha. They have really given us the tips of how the cardiac problems are arising, emerging, and how to reduce it, and what the role of metabolic illnesses in the adolescent age group. I thank Dr. Sudhir Mishra also for choosing the topic and selecting the panelist very well. I thank Dr. Hima Bindu Madam, Dr. Geeta Patil Madam, and Dr. Sushma Desai Madam, Dr. Prakashvir Arya for joining, and all the other viewers who have joined in these late hours and listened to very useful panel discussion. Thank you very much. Good night.
Thank you. Have a good night, everyone. Thank you so much.